Good morning. Happy Friday to all the lovely people that are here. Seems like you don't have anything better to do, that you're stuck with us on this Friday, right next to Christmas. But hey, we're here too. Robbie, how are you? What are you eating right now?
For those of you who know, um, Lebanon artificially claims stakes claim over this very famous spice called za'atar. Have you heard of it, Prof. Rez? No. All right, so Iran can no longer claim it. But yeah, so it is just this like delicious spice and on bread. My mom brainwashed me into thinking that if I the more I eat of it, the healthier and happier I will be. And it's definitely not true, but on our turmeric theme yesterday. But yeah, it's really, really good. So that's my a pre-run meal, Prof. Rad.
Oh, wow. So you're gonna go for a run after this?
Yes, sir. Kara and I are
With
gonna go and enjoy a nice run in Golden Gate Park.
Oh, very cool. How many miles is in store for today?
Kara, how many miles are we gonna do? Some.
Some, okay. TBD.
DVD.
Well, who's presenting the case today?
I am.
Hi, how are you? Where's your cat?
Hey, Reza. My cat is in Morocco. I will probably
Oh.
be bringing her with me after I figure out where I'm going to end up for residency.
Where are you right now?
I'm currently in New York.
Oh, wow. Christmas in New York. Do you
Yeah,
know
it's
that
been amazing.
they have a Home Alone package there that is might be a little too expensive. You spend like, I don't even know, like 1,000 or more, and you get a slice of pizza, like Home Alone in the limousine, and you get to go to the Plaza Hotel, which is really, really cool. So how's Manhattan for you?
It's been great. It welcomed me with the first snow in 15 years. So I experienced
Wow.
my first snow ever in New York this year.
What's your favorite part of the city?
Definitely Central Park.
Nice.
Yeah.
Have you been to any Broadway shows?
Yeah, Aladdin and The Lion King. But my favorite is, so far is The Lion King.
That's all. Did you watch Mufasa, the new
Well,
movie?
actually, the person I worked on the case with, Tansu and I, were planning a double date to watch Mufasa sometime this week. We'll let you know.
Yeah, let us know. I think it's on Disney and in the theater.
Yes.
All right. Who is scribing today?
Hi, Professor.
Hi,
I
Raul.
am
How are you?
Rafael. I'm
Where are
doing
you
good.
call, where are you right now, Raul?
Yeah, so I'm in Connecticut, Hartford. Yeah.
Wow. How's it going there? How are the holidays there?
Again, it's the weather again. I did not see the snow in my entire lifetime. The Currently the temperature is -10 here in Hartford. It's
Wow.
very cold.
Oh
I'm
my.
freezing whenever I go for a walk.
Well, hopefully by typing, you're going to get a little warm, increase your metabolic rate. Um,
Exactly.
who is teaching today?
I am.
Who? Oh, Ethan, how are you?
Hi, Reza. Hi, everyone.
Where are you, Ethan?
Taiwan,
Taiwan. What time is it?
at 1 a.m.
What? You don't have anything better to be doing right now, Ethan? I'm joking.
No
How's the
better
weather
way.
there?
Yeah, it's not that cold as you guys. It's 10 Celsius, but already very cold for me.
Well, that's awesome. All right, Robbie, I don't think I can delay this anymore. It seems like Jazz is saying something I haven't read yet in the chat. But why don't we go ahead and get the whiteboard up and give that first aliquot for Robbie to munch on like the za'atar bread.
All right. So in the first aliquot, we have an 83-year-old female who presents to the ED with urinary frequency, dark-colored urine, and back pain that have been going on for the past 2 months.
So, Mama, did you and Tansu work on this together?
Yes, we did. Actually, last night we spent the better part of the evening like finalizing everything. So,
Oh,
shout out to Tansu. She's currently
amazing.
on the jitney back home.
Oh, that's incredible. I'm so excited to sniff out her fingerprints on this case, but excited to learn from you. And I'm intrigued already because I think that if you really tabulated the number of patients who we see with urinary frequency, which is the first words that you prioritize within the chief concern, I think that chief concern is very, very common. And I think what's immediately unusual about this situation is the stark contrast to the base rate of urinary frequency, which often exists either in isolation, meaning the patient only reports urinary frequency, or it exists with either local urinary symptoms like dysuria, or less commonly, compensatory mechanisms like hyperhydration. So instead of being so fancy smancy, I'll just tell you that most of the time patients with urinary frequency just say they have urinary frequency and nothing else, or they say they have urinary frequency with dysuria or urinary frequency and polydipsia. And so this combination of symptoms is very, very intriguing and actually pretty unusual. And so what happens immediately when you enter a space of an unusual combination of symptoms? I think in VMR, you start to put them together and start to assume that they are somehow related and that this is a clue to the underlying diagnosis. But as we redouble our efforts to try to represent real life on VMR, I think the first thing that would happen in my mind is I would cast doubt on the probability that these things are actually related. And the reason I would say that is because all three things are actually very common, and all three things are often not diagnostic of a progressive sinister disease. Most patients with urinary frequency have a mild urinary tract infection or mild hyperglycemia. Most patients with dark colored urine are dehydrated, and most patients with low back pain, presumably this is low back pain, we haven't clarified that yet, have non-specific low back pain. And so what would I be inclined to diagnose here? I'd probably say, maybe there's a UTI, maybe the patient's dehydrated, and very likely this patient has long-standing low back pain. And that would probably be what would happen. But I think you have to be very, very careful because while that is the probable scenario, I guarantee you that if the improbable scenario is happening before our eyes today, we have to practice sniffing it out. And this is why people say the answer is in the history 99% of the time. It's not that I expect the subsequent history to be diagnostic of the condition, is I expect the subsequent history to provide robust clues as to why this default assumption may not hold. And I think one thing that Prof. Rez emphasizes is the sequence of events. And so if we learn that contrary to what all these speculative thoughts that I'm saying, that this patient has a synchronous onset of these three things all timed together, all equally debilitating, all of a sudden the hypothesis that this patient has chronic low back pain, recurrent acute urinary infections becomes less and less plausible. And so I think that the thing that I would be trying to study the most is to really pay attention to the low back pain, because I think that probably would be the most concerning symptom. So summary of the reflective thoughts on the chief concern: three conditions, all very common, but unusually packaged together. And that might be that this patient has three common conditions that coexist coincidentally, or upon careful reflection of the history, we might be able to find reason to package them together and worry more than we otherwise would be. Any other thoughts, Prof. Rez, before we get the first out of the HPI?
No, I think that's so nice. And thanks for keeping us grounded in common, diagnoses.
Alrighty, well, what you got next?
Okay, brilliant. So the patients were observed this dark urine for the past 6 weeks, so a little bit later than the urinary frequency and the back pain. She saw her primary care doctor a day prior, who sent her to the ED for further workup. On the review of systems, she denies headache, fever, chills, chest pain, shortness of breath, and abdominal pain. But currently she feels fatigued and nauseous, but she has no other complaints. On the past medical history, she has AFib on apixaban. She has a prior cerebrovascular accident with mild residual deficits and hyperlipidemia on statins and hypertension on diazide. And she also has a very recent diagnosis of MGUS with a faint monoclonal IgG lambda M spike and the kappa to lambda ratio of 2.6. The medications that she's currently taking are Eliquis, metoprolol, tartrate, alendronate, mirtazapine, atorvastatin, and diazide, which is the triamcinolone hydrochlorothiazide combination.
Well, thank you for the additional information. I'll focus on the dark urine, and I know probably this community knows that Rabih is an MGUS expert, so we'll leave that past medical history for Rabih to tackle and layer upon the foreground. But it's interesting. I haven't really had anyone with dehydration complain of dark urine because we've all experienced that where we haven't consumed enough liquids for a day. Then we go to the restroom, we urinate, and the color is dark. And most of us can make that link between decreased peel intake and dark urine because you're trying to reabsorb as much water as possible at the level of the nephron. So I think like for someone to complain of dark urine, that is such a peculiar or unusual chief concern that that would probably serve as my jumping point in this case. And the fact that it's been persisting for 6 weeks, I think gives further emphasis on what's driving this dark urine. And when you look at when someone complains of a rash, you don't want to get the history, the past medical, etc. What you want to do is you want to look at the rash and let that guide your history taking. That's like the most efficient way at solving the problem. I would apply the same technique to the dark urine. If someone has dark urine, not that I want to look, I mean, I do want to look at the urine, but more importantly, I want a urinalysis. Because the urinalysis is going to give us so much information as to what might be the possible cause of the dark urine. Before the UA comes back, I may ask some simple questions like, are you on any medication? And I would, and not the typical prescribed meds, which are important because there are meds like nitrofurantoin, rifampin that can cause dark urine. But I would ask about over-the-counter stuff or any supplements they might be taking. Particularly food dye, like beets can lead to dark urine through beeturia. So that would be simple, like history taking. Then the question becomes, if the UA is positive, you can exclude, dietary or medication induced dark urine. And the question then becomes, is this an issue with the red blood cells? Is this an issue with a pigment, or is this an issue with bilirubin? Because I don't think you can look at the specific gravity to see if there's some dehydration, but the UA is going to be so helpful. So what I'm looking at for the UA is the hemoglobin positive? Is the red blood cell positive, or is neither positive? And really, we're dealing with bilirubin that has darkened the urine. The fatigue and nausea, they're really non-specific, but it just makes you wonder that is this dark urine a clue to truly a sinister multi-systemic process that extends beyond the urinary system? And I think I would get a little more history on sort of the back pain that this patient is experiencing, because that too might be a clue to tie things together. But really, my next step, a brief physical exam, but most importantly, a urinalysis and just asking about food dye and medications that commonly darken the urine. But I'd love to pass the mic to Rabih to maybe layer on that thought process by examining the past medical history.
Yeah, Prof. Rez, I absolutely love that analysis and how you're both intrigued by the dark urine because it's unusual for patients to report it as a chief concern when they're dehydrated and where you took it. And I think that if you apply that same principle to the MGUS, in that it very much might be a distractor and unrelated when the accurate label of monoclonal gammopathy of uncertain significance is accurately made. But I think in order to accurately make that, we have to understand one fundamental thing about a monoclonal protein. And that one fundamental thing is that complications from a monoclonal protein occur in two different flavors. The most common and most taught about flavor is there is so much monoclonal protein, and as a result, by inference, there is so much plasma cells that produce that monoclonal protein, and the patient has cancer. And the cancers that are ascribed to the sheer burden of monoclonal protein are multiple myeloma, Waldenstrom's macroglobulinemia, and less commonly, B-cell lymphomas that secrete paraprotein. So these consequences are related to quantitative issues related to the paraprotein. More intriguingly and with more complexity, you can develop complications of a paraprotein because of its structure. And these are qualitative protein complications. The qualitative complications are best captured by the syndrome of light chain amyloidosis, which in 90% of people who have the condition is completely unrelated to the amount of plasma cells, often microscopic amounts, but rather how that abnormal light chain folds into a beta pleated sheet, resulting in staining of Congo red, the definition of amyloid. So when folks are diagnosed with MGUS, it is very high probability that the amount of paraprotein that they have is low, and so the probability of a malignancy driving this paraprotein is low. However, the possibility of an idiosyncratic qualitative complication is always possible. And so the criteria for MGUS is the protein has to be less than 1.5 grams per deciliter, has to be an IgG protein, and the amount of plasma cells in the bone marrow, if obtained, has to be less than 10%. The criteria for a idiosyncratic qualitative complication of MGUS is the patient cannot have a described syndrome as a result of a paraprotein, which range from cutaneous diseases like eosinophilic fasciitis to renal diseases like monoclonal gammopathy of renal significance to neuropathies to cold agglutinin disease, a whole range of complications that essentially span from head to toe. And so in an uncertain case like this one, the diagnosis of MGUS now becomes questionable. And in fact, it's not actually really questionable, because what does MGUS stand for? It stands for monoclonal gammopathy of uncertain significance. And so we, in a case of uncertainty, should be open to the possibility that the uncertain significance is now becoming certain. And so the same rigor you applied to the dark urine could be true and unrelated, but unusual. And I think the same speculation should be ascribed to MGUS. Could be true and unrelated. But if this complex of symptoms, as unusual as it seems to be now, fatigue, nausea, urinary frequency, dark urine, back pain, it's not a combination that's coalescing into a simple explanation. So now the door for a paraprotein explaining all of it has to be open. You can't be blinded by that very cool possibility and not assume any other things, but I think you have to open that door now. Most of the time when you open that door, you close it right back because you realize the patient has a regular old UTI or has low back pain, but I think we have to see what the foreground tells us before we commit to that. So I'm excited to see what Omaima has in store for us next.
Wow, that's impressive. You really didn't leave any stone unturned. So for the vitals, the patient had a blood pressure of 140/86, a pulse of 75. She was afebrile with a temperature of 36.7, and her respiratory rate was 16 with an SpO2 of 100%. She was an elderly female, not in acute distress, answering all the questions appropriately. She was normal cephalic atraumatic, and the extraocular movements were intact. The neck was supple, there was no JVD, the respiratory effort was normal, and the lungs were clear to auscultation with no real bronchi or wheezes. The heart rate was normal with S1 and S2, and there was no murmur, rub, or gallop. The abdominal exam was normal, the skin was normal with no rashes or lesions, and the extremities were also normal with mild peripheral edema on the left side. On neurologically, she was alert and oriented ×3 with 3 out of 5 muscle strength in the right upper and lower extremities, which was consistent with the prior known CVA deficits that we mentioned earlier. Can I now give you an initial set of labs? Her CBC, her white blood count was 7.7 with a mildly decreased neutrophils differentials of 13%. The hemoglobin was 8.9 with an MCV of 88, and the platelets were 260. On the chemistry, the glucose was 112, the sodium 136, potassium 5, chloride 105, and calcium 9.1. Bicarbs were 17.1, and the BUN was 101. The creatinine was 8.66, which was very elevated from her baseline creatinine from a few months ago. That was 0.73, and her GFR was 5. The INR was 1.4 and the APTT was 45.3. And I'll stop here.
It's amazing, Umaima, the disconnect between the labs and the exam. And I think just to show you, I'll pass the mic to Prof. Rez to reflect on the labs, but it goes to show you how there are many, many diseases that don't rise to the surface. And I think kidney disease is such a humbling example of that. If the patient had heart disease or liver disease, you would have certainly seen fingerprints of it on the exam. And I think the fact that you don't is very, very evocative of kidney disease, which is the number of times we have patients who are like, their creatinine is 100 million and they didn't know much beyond fatigue and stuff like that is just so marked. So the only reflection that I will share with you all is just how powerful this disconnect is and how humble you have to be. So say you're the PCP who's just, seeing a patient who's reporting these things, but you look and you use your own eyes and you don't see much. I think you have to remain humble, and this is why the labs are so powerful. They really open the door to a whole range of possibilities that the exam cannot necessarily declare. So let's keep that connection, that void in our back pocket for the future care of patients who present with non-specific symptoms. Labs are really necessary to unlock what we have unlocked. And for dissecting that, I'll pass the mic to Prof.
Yeah, that's such a great point, Robbie. It like reminds me of hypercalcemia. Like there's certain disease states that are only identified after the fact. And just Umami, to be sure, the neutrophil percentage is 13%, is that correct?
No, that was lymphocytes actually. It was
Oh,
slightly
that was
decreased.
okay. Just making sure. Thank you there. Thank you for telling us that. I think, Robbie, a lot of times in clinical reasoning, we prime our minds to tackle the case. And when that priming goes incorrect, we're likely to arrive at a wrong diagnosis. And an example is what we experienced yesterday on RLR, where you presented me as someone with like a viral syndrome. I'm not going to ruin it for everyone, but the end diagnosis ended up being something completely unrelated to the viral syndrome, or the VMR that Kirtan presented to me and Charmaine yesterday, the day before yesterday, where there was so much noise up front and a sore throat, and there was even a GN, but ultimately it ended up being unrelated, the GN to the final diagnosis, to explain the final diagnosis. So what we do here is like the labs that are of interest is the BMP, where we have acute kidney injury and we have a prior baseline. So we know there's some acuity to this. If we didn't have the prior baseline, you would still assume acute. And whenever you're dealing with kidney injury, you have to use the best framework, which is pre-renal, renal, and post-renal. In this individual, you still have to rule out post-renal because you'll get burned if you don't, but it's less likely. And pre-renal is also less likely based on the HPI. So really, and the fact that there's dark urine, it's really prioritizing an intrarenal pathology of the kidney. And I'm really using the kidney as my anchor point here because to me, that's the most prominent lab abnormality. And then I'm layering on stuff from the HPI and what Robbie taught us in the past medical history to make sense of the abnormality. And when we do that, when we think of intrarenal AKI, the disease can either be at the glomerulus, the tubule, the interstitium, or the vessels that run up along the kidney. However, if we take into account the past medical history, all of a sudden we start wondering, could there be a paraprotein that is causing a tubulopathy leading to an AKI? That's one hypothesis that's worth considering, though it doesn't necessarily have to be the case. And the way you can make progress on this is through a UA. That same UA we wanted when we heard the dark urine is going to be quite informative here. Because if all of a sudden we're getting red blood cells, white blood cells, and protein, then maybe we're localizing the lesion to either the glomerulus or the interstitial space. And remember, a lot of times multiple areas can be diseased, meaning you can have tubular interstitial nephritis. But if the UA doesn't show any red cells and there's just some protein in the UA, then it prioritizes a non-glomerular process. And with this sort of past medical history, shoots up a paraprotein. But I'm still thinking about the dark urine because I think that needs to be explained. And so the question becomes, how can we explain the dark urine with what's happening from an intrarenal lens? And there's multiple ways you can do that. One way is through red blood cells. Oftentimes, with glomerular nephritis, you don't have macroscopic hematuria, but boy, Robbie and I have seen that in discussing so many cases. It would be less common, but can that be red blood cells? And really what you're dealing with is a glomerulonephritis. And I'm totally open to that possibility, even though it doesn't incorporate the past medical history, because I don't want to anchor myself and say this must be MGUS related. Another possibility is, could that be pigments? And do you have intravascular hemolysis because of an underlying malignancy, whether it's liquid or such, leading to an autoimmune hemolytic process? And now you're seeing the pigments, and now you actually have pigment tubulopathy and the dark urine. Purely from the lens of a paraprotein, absent the connection of a hemolysis and pigments, it's hard for me to explain the dark urine. So you can see here, I'm hesitant to put my bet on a single process, but boy, that UA is going to be so helpful to either eliminate the possibility of a pigmenturia and like a intravascular hemolysis or a hematuria in the form of a glomerular process. So I think with the anemia, of course, and the history of MGUS and the AKI, you have to think about myeloma 100%. And so I think an SPEP, a UPEP, serum free light chains are all in order. Yeah, and I would love to pass the mic back to Robbie to add to that. And I think one last comment I'll just make is just the medications this patient's taking. They're taking apixaban. You can get DOACs that lead to glomerulopathy that then cause hematuria. So it's going to be really important for us to determine what the state of that UA is. And the lymphopenia, it just tells us that there's probably something going on that's suppressing, the lymphocyte production at the level of the stem cells. But would love to pass the mic back to Robbie to maybe share any thoughts, but specifically like what test or what is he doing next in the ED for this patient?
Rafraz, I absolutely love that discussion and how you took it back to the chief concern and trying to marry it with the one thing that doesn't quite fit with the dark urine. I really, really enjoy that. And I think the one thing that I'm also struggling with is how somebody can have urinary frequency with creatinine that is this dysfunctional. And I think that's an interesting reflection. It goes to show you that sometimes your kidneys can dehydrate themselves. So say you have nephrogenic diabetes insipidus and or hyperglycemia, and the source of your volume loss is the kidney itself. And so that's an intriguing possibility. but I don't see really any evidence of that on the exam. But I was just I made a note to try to reflect more and make a schema on how you can have urinary frequency plus AKI, because it seems intuitive that the AKI would halt the urinary frequency. And so it just reminded me to be careful, because I was assuming that urinary frequency means that the patient is making a lot of urine, but that's not necessarily true. Especially in a patient with low back pain, the urinary frequency may actually not represent polyuria, but represent a neurogenic bladder. And so it reminded me to be very, very careful and not assume that that the patient's PVR is going to be low. And yeah, I think, when you have back pain and kidney disease, I think that the two P's are very, very helpful, PVR and a paraprotein, to connect the two. And that's really the only thought that I have of any meaningful substance. The other kind of reflection to share with you all is just how important it is not to get lazy when you see AKI and you see kidney disease, because I think most of the time you would ignore that hemoglobin and say, oh, that's just the anemia as a result of EPO deficiency. But there are many, many reasons why patients can have an underlying systemic issue cause both anemia and kidney dysfunction. And one of them is really taking up a lot of space here, which is paraproteinemic diseases. And I think that the causes of anemia are often not so life-threatening, so you don't have to think about them urgently. But I would encourage you to have a checklist of 3 things every single time you have anemia with kidney disease to prevent the inertia that naturally happens. And that checklist is, again, reinforced here with paraprotein. The other thing that you don't want to miss is a microangiopathic hemolytic anemia, which is unlikely here based on the platelet count. And then finally, diffuse alveolar hemorrhage. So every time I see an anemia in kidney disease, I immediately collapse the two, but then I've reminded myself to think of 3 things: paraprotein, diffuse alveolar hemorrhage as a result of glomerular pulmonary renal syndromes, and a microangiopathic hemolytic anemia. So if we go through that checklist here, Prof. Rez has outlined why paraproteinemic diseases are really important. I don't see a fingerprint for MAHA. I don't see a fingerprint for DAH. But if the case twists a little bit, then we might have to re-entertain those things, but I doubt that that will happen. So for me, I think a PVR is the thing that I would want to know first, and then dive into all the tests that Prof. has ordered. I think we would often probably give the patient some fluid, even with a fluid shortage around the United States, for creatinine that's this high, seeing how much of the pre-renal disease we can wipe away from the fatigue, nausea, and lack of intake. Waimo, we're very, very intrigued. The efforts of Tansu and yourself are on display. What do you have next for us?
Yeah, wonderful. So I have the creatine phosphokinase. It was normal at 32. The transferrin saturation was 7, and the iron was 11, which were both low. The haptoglobin was 219, and the ferritin was 556. Ask and you shall receive. Now we have the UA. So the UA showed light brown color with the glucose of 70. The ketones and nitrates were negative with a small amount of leukocyte esterase. The pH was 6.5. Proteins were 100, and the RBCs were high at 182. The urine-specific gravity was 1.010, and the white blood count was 49. Urine microscopy showed sheets of RBCs, 1 muddy brown cast, and no dysmorphic RBCs. Now we have the urine total protein to creatinine ratio, which was very high at 3095, and the urine albumin to creatinine ratio was also high at 877, and we had a FeNA of 10%. We also had a hypothesis of post-renal disease, so we had an ultrasound and a CTAP. So the ultrasound showed an increased renal cortical echogenicity consistent with a non-specific renal parenchymal disease and no hydronephrosis. And on the CTAP, there was no hydronephrosis and a punctate non-obstructive left renal calculi. And we also detected some trace bilateral pleural effusions that were more pronounced on the right side, and some trace ascites.
Wow, this is incredible. Let me ask you, did you say that there were sheets of red blood cells, but no red blood cell cast? I just wanted to.
Yes, there were sheets of RBCs, but no casts. Just one muddy
No,
brown casts, and they
got it.
were not dysmorphic.
Thank you. That like really, really humbling because I think maybe I'll interpret the UA to the best of my ability and give the rest for Robbie to discuss. But like going into this urinalysis, I think when you look at the specific gravity, it's just telling you that the kidney can't really concentrate or dilute urine because you can take the last two digits, multiply it by 30, and that will give you a urine osm of around 300. And if you ask the question, what is the serum osm? It's around 300. So basically, what's going into the nephron is getting excreted without concentration or dilution. The nephrologists refer to this term as 1010, and it's most often present in the context of acute tubular necrosis. But you can see it in CKD and even in AKI. I think the red blood cells, when we saw those, because we were worried, could this patient be having um, glomerular nephritis, some hematuria leading to dark urine? But it was really difficult for us to then say, how does that explain, some of the other findings like the low back pain, the urinary frequency? And the truth is, this is where I think I was a little bit humbled, Robbie, because like common things being common, could this RBC just be the stone that the patient has? And now you're seeing hematuria from that and is unrelated to the current presentation. Now, you have to be a little cautious there. It definitely can be. And if you were a betting person, almost in anyone with hematuria and a stone, you would bet that that hematuria is a consequence of the stone. But I say you have to be cautious because you have to know the test characteristics of RBC cas and dysmorphic reds. Their sensitivity is low, meaning it's like 50 to 60%, and it's all dependent on how comfortable the nephrologist is reading the microscopic slide. And so when I was earlier in my practice of medicine, I would assume a test that's negative is negative. But now we've seen enough cases and we know the complexity of actually operating a microscope, the complexity of making a diagnosis, that you just have to temper that a little bit and still be open to the possibility that there might be something happening at the level of the glomerulus. That being said, I think that the other striking finding here is the degree of proteinuria that was detected on the spot protein to creatinine ratio. I know when you interpret a UA in the context of acute kidney injury, you may overestimate the level of proteinuria on the urine dipstick. I don't know if the same applies to the actual spot protein to creatinine ratio, but what we have here is nephrotic range proteinuria. And yesterday I was talking to a friend and we were talking about Brugada pattern versus syndrome. There's a difference between nephrotic range proteinuria and nephrotic syndrome. But whenever you see nephrotic range proteinuria, then the next question is, do they qualify for the syndrome? And so what is the syndrome? There's edema in the legs, which this patient has, and there's hypoalbuminemia. I don't know, do we have the albumin level in this patient?
It was slightly decreased.
Slightly,
Yeah.
okay. So, not enough, I think, yeah, maybe not enough yet to label this as a syndrome, but may become the syndrome at one point. That urine dips, and there's like a little bit of a disconnect here, honestly, between the degree of proteinuria on the spot protein to creatinine ratio and what the urine dipstick is showing. Because 100 is just mild, usually 300 is more severe. And so when there's a disconnect, you have to realize that the urine dipstick is detecting albumin, but the spot protein to creatinine ratio is detecting all protein, not just albumin, but non-albumin proteinuria. So I really wonder if this is telling us that the issue is really at the level of the tubules, and what you're seeing there is more of a non-albumin proteinuria in the form of like a light chain. So I think what I would do with this data on the UA is I would say, okay, maybe I have another explanation for the RBC. Maybe the issue is at the tubules. The patient is losing a lot of protein, but I don't think it's albumin that's the main culprit, which would prompt me to send the SPEP, the UPEP, but most importantly, you have to realize is the serum-free light chains to see if we're dealing with AL amyloid, which can cause this degree of tubulopathy. I'm going to pass the mic to Robbie to, add anything he wants to the UA, but also interpret the other findings that was revealed.
Professor, I think this is an amazing analysis of the UA. I completely agree. I'm right there with you. And I think that the rest of the data really just says that there doesn't seem to be any systemic fingerprint of the disease outside the kidney, except that the patient is accumulating consequences likely related to nephrogenic volume overload. But I think that interpretation may change with more data. So I think that really my problem representation is very much so that this is a patient with disproportionate severe kidney disease without much proportional systemic involvement. But of course, one aliquot later, they may be hypoxemic with lung infiltrates, or they may get confused, so that may change. But I think that's the current problem representation. And all I'm thinking about, Profres, honestly, is just sort of like from the management reasoning right now. And I think that in the absence of any cardiovascular risk factors to suggest endocarditis, that's the only infection that I can think of that looks that triggers a picture like this. And so I think what we're really primarily left with is a steroid responsive condition like an autoimmune glomerulonephritis, or a condition that is as a result of a paraprotein that will require B-cell depletion therapy. And so I think all I will emphasize is the urgency for a diagnosis here, because the probability that a patient will need some kind of immunosuppressive therapy, be it as non-specific as steroids to as targeted as bortezomib, I think is very, very high. And so the question really is, how do we proceed next? I would say that that it would probably be a healthy debate. I don't think there would be much debate about the value of a kidney biopsy in this patient, though there might be some debate about the safety of it given her anticoagulation. Though I think when you really scrutinize the data, the risk of complications of a renal biopsy, even in patients who have been on anticoagulation, is not very, very high. But I think the healthy debate would be, as we weigh in the possibility of empiric steroids versus B-cell depletion therapy, the immunosuppressive effects and the toxicities of B-cell depletion therapy, like rituximab, are often so high that is rarely started empirically. And I think that is probably not so much true for corticosteroids. And so I'll be the one today, instead of you, to fall on the sword. I think that we really should consider whether we should give this patient steroids. And I say that for two reasons. One is the patient may have an ANCA vasculitis or anti-GBM disease. And that is the moment you start treatment is the moment you can reverse renal failure. But actually, it turns out that in the umbrella term of monoclonal gammopathy of renal significance, which Chiara presented to us a case about a couple of months ago, lack of response to steroids is a clue that the paraprotein is actually significant and that beta cell depletion therapy is required. So the stubbornness of the disease on steroids may afford us a diagnostic clue, with the caveat that, of course, ANCA vasculitis can also be stubborn. So I think if this were me, I would probably write myself for a gram of Solu-Medrol. I would want a renal biopsy yesterday. And I would be calling the pharmacy to make sure they have stocked all the beta cell depletion therapy one might need for all the variety of conditions under the umbrella term of monoclonal renal significance. And if Umaima then says, hey, this is Bartonella endocarditis, and the cat that was in that was hiding, that was brought up earlier in this conversation, I will be forever humbled. But that's
you're just being offensive, suggesting that her cat has Bartonella and was
all,
the culprit.
I think all cats have Bartonella problems, but sure.
Listen, I wanted to just dance with you for a second, because I think that, first of all, thank you for falling on the sword of steroid, because if it's not you, it's me giving the 1 gram virtually. But let me just for a second remove the red blood cells, Robbie, from that UA. Then I just want you to share, then what is your thoughts there?
Yeah, I think that the red blood cells, if you remove the red blood cells, I think the degree of proteinuria that you have here is impressive. And I would say pretty focused on a glomerulopathy. I think the red blood cells make it an itis, the lack of them make it an opathy. The caveat would be that systemic hypertension and or isolated renovascular hypertension may induce proteinuria. So the fact that this patient isn't hypertensive reduces that possibility. But I think if you just remove the red blood cells, I would believe this is still a glomerulopathy based on the amount of protein. And I also just saw that the albumin to creatinine ratio is also elevated. And so the glomerular disease would be high, but I've seen patients with a thrombotic microangiopathy or a TMA, because they get so much local renovascular hypertension, that they also leak. So I think the case for a significant component of glomerular disease is decently high based on the albumin to creatinine ratio, but I think a concomitant interstitial component is very, very plausible, especially if there's a big gap between the protein to creatinine ratio and the albumin to creatinine ratio, which would suggest either immunoglobulins or a tubular interstitial protein.
Dude, I love that so much because like I'm also noticing, this patient's on apixaban, they have a stone. And so it's so easy to hypothesize that they're going to have some degree of hematuria. And I just feel like I don't know enough about the albumin to creatinine ratio. I don't send that often in the hospital setting, but I know enough about like the urine dipstick and then the quantitative spot protein to creatinine ratio. And I think I'm making the leap that there's a disconnect there in the degree of albuminuria and the degree of proteinuria, like total proteinuria. But I think doing that math of like actually subtracting and seeing how much of that proteinuria is due to albuminuria is how you clinch the diagnosis. And it can take you from a space of glomerulus, because a lot of people will have glomerulopathy at the age of 83 with the background of hypertension, and put you more in the space of a tubulopathy, and then prioritizing sort of the serum free light chains and like amyloid as the culprit. But both are fair game, and I don't think you can dismiss one or the other. But I think it's pretty easy. You either do that math, and you might be in the tubule if it's non-albumin proteinuria predominantly, or you just wait for that serum free light chain. If that's like really high, then you still will probably get the biopsy to show that it's invading the kidney. But then I think that clinches. But I think it's really cool to look at the disconnect, or whether it's the reasonable expected amount of proteinuria based on the albumin. I'm just using the dipstick because that's all I know how to use.
It's just poetry there. If you're new to the space, you probably have to listen to that over again, but that was absolutely amazing. Thank you, Prof. Rez.
That's brilliant. So a repeat UA was done a week later, and it did show RBC casts. We also ordered a kappa to lambda ratio, which was 2.1. The kappa was 19.77, the lambda was 9.4. The IgA, IgG, and the IgM were all within normal limits. We also ordered Hep B, Hep C, and HIV serologies, which were non-reactive. And the serum immunofixation electrophoresis showed a normal pattern and no monoclonal proteins. Before handing the mic back to you, I want to mention that during her hospitalization, she developed dyspnea at this point.
My, sneaky, sneaky. I just want to say before we reflect on this case that actually I've been suppressing this thought for a long time to save it to the end. And it's just amazing to have. I remember one of your earlier cases when you presented a case of acute leukemia a long time ago. And just to see how much your ability to project your confidence and understanding of medicine has grown over. You started at a ridiculously high level, but it's really cool to see just how well and how improved your storytelling is now, and how you're leaving the twist till the end. I absolutely love it, and thank you to both you and Tansu for bringing such an incredible case. I'll pass the mic to Prof. to reflect on the shortness of breath. I think it's a really powerful twist in the case, potentially powerful twist in the case. But I want to steal his thunder again and just emphasize that one of the earliest episodes of the Clinical Problem Solvers, Prof. Rez skyrocketed to fame for a famous quote. He said, "I trend my UAs like I trend my troponins. And I think that that point is self-evident in this case. And you made it with a little less humor and more sophistication today by talking about sensitivities of these findings. But I wanted to share that now very, very famous quote. So thank you, Omaima, for reminding us of the value of trending the UAs. And I think now the specificity of RBC Cas is very, very high and shows you that you're leaning more towards glomerular diseases when at first glance you couldn't. So I think that's a really powerful evolution of the case. But what are you thinking now, Professor?
I'm just like thinking how grateful I am for this case and what an educational case for everyone. And if you don't mind, I'd like to just highlight a few things that we did that I'm really proud of. Remember in that first aliquot, Robbie, you were like, urinary frequency is common enough that it doesn't really jump on my plate to try to explain. And back pain is common enough. And even though we have the history of MGUS, and you're starting to think, oh, is it myeloma, back pain, anemia? But then it wouldn't explain the dark urine. And I was proud of myself for saying the dark urine is really an unusual finding that people don't often report. And if they're reporting that and it's persistent and it's not due to a medication or a food dye, then it must be explained. The other thing that I really enjoyed about this case, I'm not saying it as if we know what the diagnosis is, but what I enjoyed was how we weren't quick to dismiss the negative UA microscopy, the negative urinalysis in form of microscopy. We said that, look, sometimes these sensitivities are so low that you got to repeat it. But there being a stone in a Pixaban, there's another very practical explanation for RBCs in the urine. But because we can't miss a glomerular nephritis, we didn't dismiss that hypothesis. So I also appreciated that. And then I love what you did in terms of your schema of anemia and AKI. And now I'm trying to remember that, where you said, I think about diffuse alveolar hemorrhage, paraproteinemia, microangiopathic hemolytic anemia. And you're saying, and you primed your mind that if this patient develops dyspnea, then maybe that's actually diffuse alveolar hemorrhage that's subclinical at the current moment, but then becomes clinical. So I mean, this was just such a great exercise and like considering multiple pathways and then weighing what's we can't miss and being open to the possibility of that ultimately showing itself and not being rooted in the MGUS as being the primary cause. All that being said, the kappa lambda ratio is low. You would expect that in someone with this, so it's not serum-free light chain. There is no monoclonal spike. And now that we have cast, we know that the glomerulus is inflamed. And the glomerulus is inflamed as you're getting these red blood cells through, they're binding with a TAM Horsfall protein, and therefore leading to RBC Cas. Though I just had another thought, which I will have to look up later, that if you have hematuria for non-inflammatory glomerulopathy, you don't get cast, but I'm not sure why if you still have those TAM Horsfall proteins being secreted in the ascending loop of Henle. But let's temper that thought and focus at the case at hand. All of a sudden, we need imaging. And I would argue that you just go to a non-con CT of the chest for this patient because an X-ray may not catch the subtleties of diffuse alveolar hemorrhage. And if we find nodules, which is X-ray might not catch, we might prioritize an ANCA-associated vasculitis like microscopic polyangiitis versus if we don't see any nodules. But really the two, the diseases that take center stage here, small vessel vasculitis and the glomerulus is a small vessel. And you can break this down into immune complex, ANCA, and anti-GBM. And ultimately, you need a biopsy of this kidney that Robbie had requested earlier to see what the immunofluorescence pattern is. Is there a linear pattern of anti-GBM? Is it small deposits of immune complex? And is it posse-immune like the ANCA? So I think we could theorize and speculate based on her age, et cetera, like which one of these might be it. But in reality, it's really the kidney biopsy. In the immune complex category, you can get diffuse alveolar hemorrhage in lupus. You can get it in cryoglobulonemic vasculitis, but it would be so odd for that. I'm favoring either an ANCA-associated vasculitis. Actually, I'm favoring ANCA-associated vasculitis over anti-GBM. But ultimately, you send the ANCA serology, but you know those are not perfect. And it's MPA, GPA, EGPA. Here, MPA is, I think, prioritized, though GPA is a possibility. And then you get that biopsy. But basically, Robbie, my next steps is a CAT scan to see if the lung is involved, to frame it as a pulmonary renal syndrome that has a glomerulonephritis, because we know all pulmonary renal syndromes aren't diffuse alveolar hemorrhage and GN, and then to send the serology and get the biopsy. If the ANCA serology comes back super, super high, you might not, when I say ANCA, everyone, I'm talking about not only ANCA, but the MPO as well, because you got to send those sub serologies to see the PR3 and the MPO and the ANCA, because if they're super high, you might not even need a biopsy. But I'd love to pass the mic to you, Roy. If there's anything else you like were able to gather to prioritize one of these conditions.
Yeah, no, I think that's absolutely superb, Prof. Rez. I think the ability of the CT chest to distinguish between diffuse alveolar hemorrhage and nephrogenic pulmonary edema is high. It's not perfect, but it's high. When you see central opacifications without pleural effusions, that suggests DAH. I think it'll be tricky in this patient because we already know she has bilateral pleural effusion, so she probably has a component of volume overload, and distinguishing underlying DAH will be very, very tricky. And I think this case ultimately shows you need tissue. You ultimately need tissue. All we really know is that her glomeruli are bleeding. That's all we really know. And ultimately figuring out why they're bleeding is going to require that tissue, and the serology and the CT test will supplement that. I just wanted to share one really an unrelated teaching point, is to answer the question, what happened to her paraprotein? Did she suddenly cure herself of her paraprotein? Because she had it before, where'd it go? And the answer is no. She did not cure her paraprotein. Her paraprotein is at such a small level that is now cannot be detected amongst the storm of proteins that are accumulating as a result of her kidney disease. So the sensitivity of a serum protein electrophoresis plus immunofixation in kidney disease is dramatically reduced. So say she actually does have, she probably doesn't, but say she does actually have paraprotein related disease that is heavy chain, not light chain. How would you find it? This is the one time where urine protein electrophoresis with immunofixation is required to detect the paraprotein, because the amount that's accumulating in the serum of other proteins dampens the signal. So she didn't lose her paraprotein. It's there. It's just now camouflaged by everything else that's going on. So just wanted to emphasize that point. But I have nothing to add to Prof. Rez's wisdom. And I think a biopsy is really, really key in this case. Well, Maima, what do you have in store?
Yeah, well, first of all, to answer Dr. Professor's question, the BP slightly increased to the 150s, but it's not very high from her initial BP. So we ordered first a chest X-ray that showed bilateral perihilar ground glass and consolidated opacities with associated interlobular septal thickening and bilateral pleural effusions, more pronounced on the right side. I have a clip of this CT chest, but probably for the sake of time, I can just read the reports. What do you think? Okay. So the CT chest showed bilateral pleural effusions and diffuse ground glass opacities with interseptal thickening, concerning for DAH, as you guys suspected. We have a first set of antibodies. The anti-PR3 were negative. The ANA was positive at 1 to 320. The C3 and C4 were within normal limits, and anti-PLA2R and anti-streptolizin O were both within normal limits. And the final aliquot will reveal the diagnosis.
I'm very, very intrigued by that. So it sounds like the PR3 is negative and the ANA is very positive, but the complements are normal. I think to just rapidly chat, I think that normal complement-T-MIC glomerulonephritis is an interesting subspace of glomerular diseases. And I think the caveat with normal complement-T-MIC is that normal complement-T-MIC diseases can ultimately if you are hypocomplementemic, you remain hypocomplementemic. And so an example would be if you have endocarditis related GN, you're hypocomplementemic. Sometimes normal complementemic glomerulonephritis actually evolves into hypocomplementemic, so that's the caveat there. But I would say if you're being strict, normal complementemic GN prioritizes 4 diseases: ANCA-associated disease, monoclonal gammopathy of renal significance, IgA nephropathy, and anti-GBM disease. And so here, we don't know the anti-MPO titer yet. We know the PR3, and PR3 correlates with GPA, and the PR3 is positive in 90+% of patients with GPA. The anti-MPO titer, however, for microscopic polyangiitis is positive in 70% of patients. So the possibility of ANCA-associated vasculitis looms large. And I think the question really becomes, what do you do with the highly positive ANA? And the highly positive ANA opens the door to lupus, which is then again closed a little bit by the fact that the complements are normal. Most patients with lupus nephritis have hypocomplementemic disease. So if we just use the differential diagnosis of normal complementemic glomerulonephritis, ANCA, possible, but probably not GPA. Monoclonal gammopathy of renal significance, very possible, but unlikely to produce diffuse alveolar hemorrhage. IgA nephropathy, very possible, especially with the fact that this patient has an anticoagulant on board, potentially causing anticoagulation nephropathy, with the two of those are linked. And then finally, anti-GBM disease, very, very possible in this patient. And so I think that this goes to show you that the serologies that we get really are help us refine our educated guess. The biopsy is going to tell you, is this posse-immune, is this lupus, is this IgA, or is this paraprotein deposition? And so our educated guess will be further refined by knowing what the MPO positivity status is, or if there are any subserologies to that ANA, anti-Smith, anti-dsDNA. But ultimately, tissue is going to be the issue because the serologies are very, very messy. So that's my rapid fire reflection on the rheumogram that you shared with us. Prof, has anything to add?
Did you say rheumogram? I love that.
Rheumogram.
That was beautiful, man. This really feels like when we're on stage. I don't know where it was. It was somewhere in the South, and you just like broke it down. And I think you're like, the patient needs one of the D's, and it was, or something. You're like, they either need steroid or doxycycline, but you said it in a much better way. But in any case, I think I'm really looking forward to seeing the answer. But you know what? It's Christmas time. I'm gonna just guess MPA.
Okay, so first we have 2 serologies that I left out, which were the anti-MPO antibodies and anti-GBM antibodies, which were both positive, the 4.9 and 8 respectively. The patient did get a renal biopsy, and on his pathology, we had a crescentic glomerulonephritis with linear IgG deposition, confirmatory for anti-GBM disease, but the electron microscopy did not show any immune complex depositions. So this was an anti-GBM glomerulonephritis, and the patient was also double seropositive for both MPO and ANCA. Great job, guys.
My Christmas wish didn't come true, but the I will say that Robert, do you know, can you get an overlap between the I think
Yeah, I think
overlap
your Christmas wish
syndrome.
did come true, Prof.
Yeah,
Rez. I
it should.
agree. Go for it.
Yeah, I think there is this overlap between ANCA and anti-GBM. And the reason it's important to frame it as such is because anti-GBM is really, really messy and has a high risk of recurrence. And it can be a very difficult entity to manage in the long run. So this is unfortunate, but it just tells you, like, and when you're in that rheumatologic space, we know there's mixed connective tissue disease, and there's an overlap of a bunch of these autoimmune diseases. The same thing happens at the level of the glomerulus. And so it seems like you're having an overlap here of ANCA-associated vasculitis and anti-GBM. It has management implications. Like, that's why it's so important to be able to distinguish these two. But we had an expert, Jazz at Hopkins, who was the anti-GBM expert, and he taught me a lot about this particular entity.
Yeah, I have nothing to add to that. I just want to commend Omaima for an incredible case presentation to really dive us through the bread and butter and all the way down to the esoteria. And I'm just learning, I'm going to share a new piece of learning that I just had with you all, which I have to refine. I've been all about like how you need biopsy for glomerular disease, but actually this case shows you to diagnose the rare condition of dual ANCA and anti-GBM disease, you really need the serology too. That's because in ANCA-associated glomerular disease, it's pauciimmune. You don't see much on biopsy. So from the perspective of the histopathologist, ANCA is, I don't see much. So what happens from a pathologist perspective when they get the rare scenario of actually having ANCA GBM overlap? The pathologist will never be able to tell you, as far as I know, that the patient has ANCA GBM overlap. All they can see is the linear staining of GBM. And so it is the role of the clinical correlation with serology and with the extra-renal manifestations that allow you to render the diagnosis of the overlap syndrome, which has tremendous implications, as Prof. Rez said. So I think this case teaches me that it's really, really important to actually complement the serology with the biopsy. Because while the biopsy is the gold standard, the serology can actually really, really shed light on the one thing that the pathology does not show. And it's in the name, pauciimmune. I can't see much. And so I will have to take back the point that I made earlier that it's all about the biopsy. I think a more accurate point is it's all about correlating the serology with the biopsy. And I really appreciate Omaima for teaching me that point today. It was really awesome.
Robbie, you're 1 for 1 on the pulsed steroids, man. I'm 1 for 2.
Yes.
I gave it to that patient with endocarditis. You're 1 for 1, buddy.
Omaima, I'm really curious if you want to share what thoughts, reflections you had on this. I know we're over time, but I think it's really, really a really enlightening case. My mom has some thoughts she's sharing about her experience in the jacuzzi, but maybe we'll pause those to hear yours.
I learned that for the anti-PR3, the anti-PLA2 glomerulonephritis, it's the only glomerulonephritis where we don't need the renal biopsy. This is something that Tansu taught me yesterday, and the blood test alone can confirm the diagnosis. I don't have much to add. You guys summed it up. And I also learned that, when you have the overlap, you have obviously a worse prognosis. And just to wrap it up, huge shout out to my friend Tansu. We had the perfect date night yesterday, chatting about the case and learning from each other.
I can't tell you how much joy it brings me to see you guys hanging out and connecting and sharing your love of medicine. That's so cool. For those of you who don't know, Omaima and Tansu are 2 of the 4 leaders of the case review committee, are the very reason why all these incredible cases keep coming to us. And it's amazing to see them combining forces to put this case together. And I think it showed today. All right, Ethan, you have the unenviable task of trying to summarize such a complicated case. Take it away, my friend.
Thank you, Omaima, for such an educational case. I learned a lot, and Reza and Rabi for the amazing discussion. So we start with a 83-year-old female presented with urinary frequency, dark colored urine, and back pain for 2 months. And in urinary frequency, we could approach it in 3 ways. Most commonly, a patient presents with isolated urinary frequencies, or accompanied with localized genital urinary symptoms, or as a compensatory mechanisms due to overhydrations. And Reza pointed out a great point on dark urine, that it is actually an unusual complaint of a patient, and also unusual with persistence. And in such patients, we need to obtain medical history, especially over-the-counter drugs and supplement history. And after excluding those exogenous causes, we have to consider it could be caused by pigments or RBCs or bilirubin, which we can prove in the urinalysis. And then we know that the patient had a past medical history of MGUS. And Rabi teach us that the complication of MGUS could happen in 2 ways. First, it could happen due to the underlying plasma cell neoplasms, or it could be caused by the complicated structures of the paraprotein itself, like AL amyloidosis depositions, and causing neuropathies or MRGS. and etc. And then in left, we found that the patient has severe AKI. And approaching with AKI, we could approach it into pre-renal causes, renal causes, or post-renal causes. And with the patient showing red blood cells in the urinalysis, we were thinking about glomerulonephritis. And Reza told us a interesting phenomenon that actually glomerulonephritis rarely causes macroscopic hematuria, but rarely it still could happen. And another way to connect the dots of dark urines and GN and other systemic features is by intravascular hemolysis causing pigment nephropathies. And then Rabih also tell us an interesting observation of AKI and urinary frequency, because we would usually assume AKI to be oligouric and urinary frequency to be polyuric. And in this case, we have to check PVRs for post-renal causes, and also think about paraproteinemias causing neurogenic bladders. And in the UA, we found that the patient have muddy brown cast, and it is result of a damaged and dying tubular epithelial cells that slow into the urines, and it could happen in acute tubular injuries or CKDs or other conditions. And because of the severity of this patient, we have to think about starting B-cell depletion therapy empirically, but that is very debatable. So we could think about starting steroid first. And if steroid is non-responsive, it could actually give us a diagnostic clue to a severe monoclonal gammopathies or ANCA vasculitis. And in this patient, he also has severe proteinuria, and proteinuria could be caused by glomerular disease, renal vascular hypertension, and it may not be due to systemic hypertension, but could be due to local renal hypertension due to TMA, or could be due to tubular causes. And in this case, it's likely glomerular origin because of the degree of proteinuria and lack of hypertension and high albumin creatinine ratios. And we found that the patient also have developed component of dyspnea which make us think about pulmonary renal syndromes, and it could be caused by ANCA vasculitis, anti-GBM disease. And in ANCA negative cases, it could be caused rarely by IgA vasculitis or cryoglobulinemia and etc. And Rabih at last tell us a very good pearl of that the sensitivity of SPEP with IFE could be greatly reduced in severe kidney disease because of accumulations of other proteins. And in normal complementogenic glomerulonephritis, it could be caused by 4 causes, includes MRGS, IgA nephropathies, ANCA vasculitis, or anti-GBMs. And finally, we found that patients have anti-GBM disease. And diagnosing anti-GBM disease, differentiating the anti-GBM disease and ANCA vasculitis, we really need to combine all the factors, including clinical pictures, the serologies, and pathologies. Thank you so much. And this is such a mind-blowing case. I really enjoyed it.
Ethan, I think this is well worth staying up till 2 a.m. for. It was absolutely awesome. And I cannot believe that you're this functional in the middle of the night. Don't call me and ask me to do teaching points at 1 a.m. You'll get a very subpar job. That was really well done. Huge shout out to Rahul for scribing, and with the sneaky assist from Shema, where I was watching Shema's name cross over the whiteboard. And a lot of love to my Montansu for an awesome case. Prof. Rez, have an awesome rest of your day. Thank you for hanging out. See you guys next time.